this video, we are going to look at all the slides under general pathology along with a case study associated with each of those slides. The timestamps for individual slides are provided in the video. So if you want to skim through the video or skip through certain slides, you can do that by using the timestamps. An 18 years old boy came to ER with pain in the right lower quadrant, vomiting, fever for 1 day. His WBC count is increased. So there are four important features that have been mentioned. First, there's right lower quadrant pain. Second, there's vomiting. Third, there's fever. And then the WBC count has been increased. So there's your patient. There's the right lower quadrant. And the pain is present within the right lower quadrant. Within the right lower quadrant lies the McBurney's point, and behind the McBurney's point is present appendix. When there is right lower quadrant pain, there is a high probability that it is the appendix that has been affected. When appendix gets swollen or it gets inflamed, you call it appendicitis. And due to appendicitis, you observe pain within the right lower quadrant. What exactly happens during appendicitis? The appendix, the vermiform appendix, somehow gets obstructed. Within the vermiform appendix, there is continuous secretion of mucus. Since the mucus has nowhere to go, because the outway is blocked, the mucus starts exerting pressure on the wall of the appendix. This in turn triggers inflammation. And inflammation is associated with pain. The pain is seen at the region of appendix, and that region is obviously McBurney's point, which is present within the right lower quadrant. Sometimes the pain might initiate firstly at the periumbilical region, and this pain then later shifts near the McBurney's point or within the right upper quadrant. So during appendicitis, the pain is in right lower quadrant. Sometimes it can be periumbilical region, which then later shifts within the right lower quadrant or around the McBurney's point. Okay, that's for the pain. What about WBC count? Within the appendix, it's not just mucus that is present. There are bacteria or normal flora that is present as well, like E. coli. So this bacteria, it's entrapped within the appendix as well. So the bacteria grows in number and it has nowhere to go. In order to control these bacteria through inflammation, come your soldier or neutrophil cells. When neutrophil cells invade this lumen to take care of the bacteria, there is formation of pus. For neutrophils to come, obviously within your blood, the level of neutrophils has to increase, or there must be neutrophilia. So that's why when blood is tested, an increased WBC count is seen. So there's right lower quadrant pain, increased WBC count. So there's a possibility that this person has acute appendicitis. However, let's look at the features in the microscopy to confirm this diagnosis. So here's your microscopy. Here's your microscopy. Here's your microscopy. What you are looking at is the transverse section of appendix. So there's your outermost serosa, the longitudinal muscle, circular muscle, submucosa, and mucosa. There's your outermost serosa, longitudinal muscle, circular muscle, submucosa, and mucosa. Within mucosa, there is muscularis mucosa, there's lamina propria, and then there's epithelial mucosa. Okay, first thing, at the wall of the appendix, at the region of serosa, there are blood vessels, and within these blood vessels, you can find thrombosis. So you can find thrombosed blood vessel in the wall. Second, since continuous trauma is being exerted on the inner wall of the appendix or on the mucosal layer, there are parts of mucosa that are ripped off from its origin. So you can find slurred mucosa. And the most important feature or the hallmark feature is that During inflammation, to take care of the bacteria, neutrophils are sent, right? These neutrophils, they are not just present within the lumen, they even infiltrate the wall of the appendix. So you can find neutrophil within the muscular layer. There's your circular muscle, there's a longitudinal muscle, and then you can find the nucleus of neutrophil throughout the muscular layer. This is the hallmark feature. Here's the hallmark feature. So there's your circular muscle or the muscular layer which contains the nucleus of neutrophils. Neutrophils, why? Because it is acute condition. So neutrophils. So that's the feature of acute appendicitis. What could happen if it is not treated on time? Okay. See, continuous pressure is being applied on the wall. There's blood vessel in the wall. The blood vessel gets compressed as well. As a result, there is ischemia and parts of appendix, wall of the appendix gets necrosed. As a result, it ruptures and the inner content comes out. So the bacteria also comes out within the peritoneum. And your immune system reacts to this infection by the bacteria and causes something called sepsis. Secondly, there is also formation of abscess, because within the lumen there is pus formation, right? This pus comes out and then the pus gets localized, which results in the formation of abscess. Okay. Here are a few practice questions for you. So there's your young female who is presented with right iliac fossa pain. There's your adolescent who is presented with periumbilical region pain. You can find the features, you have the microscopy, you can do the question on your own. A 40 years old female is presented with steady colicky epigastric or right upper quadrant pain, nausea, vomiting, and intolerance for fatty food. So there is right upper quadrant pain. The right upper quadrant contains your gallbladder. Here's your gallbladder and then here's your cystic duct. The gallbladder stores bile produced by your liver. Bile is responsible for the digestion of fat. Let's say this gallbladder gets obstructed at the region of cystic duct due to a stone. As a result, the bile gets accumulated inside and starts exerting pressure on the wall of the gallbladder, leading to the inflammation of the gallbladder. And the inflammation of gallbladder is what we call cholecystitis. So during cholecystitis, there is inflammation of the gallbladder, and since there's inflammation, obviously there is pain associated with it. Where is the pain going to be? The pain is going to be where the gallbladder is, and the gallbladder is present in the right upper quadrant. So the pain is going to be in the right upper quadrant. Second, since the bile has no way to go out, obviously the fat is not going to get digested properly because it is not going to get the bile from the gallbladder. So obviously the patient is going to have intolerance for fatty food. Okay, let's look at the microscopy. Here's a microscopy. Here's a microscopy. Here's a microscopy. What we have is the transverse section of inflamed gallbladder. Within this transverse section, we can see the following things. There's your innermost epithelial mucosa and then outermost serosa. There is fibrosis of serosa. Within lamina propria and submucosa, you can find inflammatory cells because inflammation is going on, and the inflammatory cells are macrophages. But then the most distinct feature of all is Rokitansky-Askov sinus. What is Rokitansky-Askov sinus? See, there's innermost layer of epithelial mucosa, right? This epithelial mucosa shows outpouching, and then this pouch, it comes off. This pouch, which is present in the form of a sinus, is Rokitansky-Askov sinus. See, so there's your epithelial mucosa, which is lined by epithelium. From this epithelial mucosa, outpouching takes place and a sinus comes off, which is lined by the same epithelium. So this comes from this epithelium or this mucosal layer. This sinus comes off. This sinus is called Rokitansky-Askov sinus. See, there's your outermost epithelial layer there's your innermost epithelial layer of mucosa. This layer, it comes off. It comes off. The same cells are present here as well. See, it could have been acute cholecystitis, but it is chronic because there is fibrosis of serosa, and the inflammatory cells that are visible are not neutrophils, they are macrophages. Okay, I want you to find Rokitansky-Askov sinus in this microscopy as well. A 7-year-old girl presented with left-sided cervical lymphadenopathy. She had a history of fever for last 3 months and her erythrocyte sedimentation rate is increased. So there's your cervical lymph node, and the inflammation of lymph node is what we call lymphadenopathy. Adeno, because after inflammation, the lymph node kind of looks like a gland. That's why adeno. Okay, there's your cervical lymphadenopathy. Upon blood testing or testing the sedimentation rate of red blood cell, it is seen that the sedimentation rate is increased. This right here is simply a general marker for inflammation. When there is inflammation, the erythrocyte sedimentation rate increases. But the main point is your cervical lymphadenopathy. So there is a high chance that there is infection of Mycobacterium tuberculosis. Let's confirm this with the help of microscopy. Here's your microscopy. Here's your microscopy. In a microscopy, during infection by Mycobacterium tuberculosis, you can find granuloma formation. In granuloma formation, there's your central multinucleated or centrally present multinucleated giant cell, and these multinucleated giant cell, they are surrounded by epithelioid cells. So there's your multinucleated giant cells. These multinucleated giant cells are surrounded by epithelioid cell. You can also find Langhans type of giant cell which has horseshoe shaped nucleus. So there's your granuloma formation where there is centrally present giant cells surrounded by epithelioid cell, centrally present giant cells surrounded by epithelioid cells. A 25 years old girl is presented with benign encapsulated sebaceous subepidermal nodule filled with keratin material on the back of the neck. So on the back of the neck, there's a benign nodule, and this benign nodule contains keratin deposition. This keratin is present within a capsule, and this capsulated keratin deposition is present under the epidermis or at the level of epidermis and dermis. This is your epidermoid cyst. Let's look at the epidermoid cyst under a microscope. This is what it looks like. This is what it looks like. So under a microscope, there's your epidermoid cyst which has keratin deposition inside the cyst, and outside there's the wall of the cyst. The wall of the cyst is made up of stratified squamous epithelium. See, the outermost layer of the skin or the epidermis is also made up of stratified squamous epithelium. Under epidermis, there's your capsule which contains keratin. The wall of the capsule is also made up of stratified squamous epithelium. So under a microscope, it seems as if the skin has been turned inside out, because inside there is stratified squamous epithelium, when in normal scale the stratified squamous epithelium is supposed to be present outside. By the way, this stratified squamous epithelium is not that of the skin, it is of the cyst which is present under the skin. So this is your epidermoid cyst. Since the keratin is present inside the skin, there is keratin deposition inside the skin where it is not supposed to be. Keratin is not supposed to be inside your skin. There are inflammatory cells present at the region of keratin deposition. A pale region of kidney was biopsied under a microscope. Upon observation, the renal tubules had lost nuclear and cytoplasmic integrity, but the architectural outline was still intact. The highly eosinophilic areas were surrounded by inflammatory cells and fibroblasts. So here's your kidney and here's the pale region of the kidney. This pale region of the kidney has gone through necrosis, and the type of necrosis it has gone through is coagulative necrosis. Let's look at coagulative necrosis under a microscope. So here's coagulative necrosis of the kidney. You can see renal tubules right here. If you look carefully, you can see that within renal tubules, the cytoplasmic content and the nucleus, they are no longer present. So here's your renal tubule, there's no nucleus or cytoplasmic content. However, the outer architectural outline, the architecture is still intact. The architecture is still intact, but then the nucleus and the cytoplasmic content, they are gone. So it gives off a tombstone like appearance. Like in case of tombstone, there's your outer outline and then inside it's completely bland. Similarly, here's also there's your outer architecture which is still intact, but then the inner stuff, they are gone. So it becomes completely eosinophilic. That's coagulative necrosis. A white and CZ area of swollen lymph node was biopsied under a microscope. Under observation, the focus appears as amorphous granular debris within a distinctive inflammatory granulomatous border. Tissue architecture is completely destroyed or obliterated. So there's your lymph node. This lymph node shows necrosis at regions. And this necrosis is caseous necrosis, which has occurred due to Mycobacterium tuberculosis. This is a case of lymphadenitis. So your lymph node is enlarged, and then parts of this lymph node has gone through necrosis. Since this necrosis shows visible yellowish white CZ areas, it's your caseous necrosis. In caseous necrosis, under microscopy, you will be able to see granuloma formation. In granuloma formation, in the middle, there's your caseous necrosis caused by Mycobacterium tuberculosis. Surrounding it are your giant cells, multinucleated giant cells. Surrounded it are the epithelioid macrophages, and the surrounding epithelioid macrophages are lymphocytes. Under microscopy of uterus, deposition of brown pigment was seen as below. And you can see at areas of uterus, there is deposition of brown pigment. This brown pigment is none other than your melanin. So under microscopy, if you see deposition of certain pigments, and if they are brown in color, it's melanin. A pipe stem like rigid artery was biopsied, and under H&E stain, highly basophilic areas were seen. So there's your artery, and this artery is quite rigid. One possibility for it being rigid is the deposition of calcium in the wall of the artery. It will make the artery as rigid as a pipe stem. But then let's verify that with the help of a microscopy. So here's your microscopy, here's your microscopy, here's your microscopy, here's your microscopy. Under microscopy, upon applying H&E stain, what we can see are areas that are highly basophilic. And these areas that are highly basophilic, they show areas of calcium deposition. So this is a case of pathological calcification. See, calcium is supposed to be deposited in bone and teeth. When calcium deposition takes place in tissues other than bone and teeth, that's pathological calcification. And this deposition of calcium in tissues is seen in the form of highly basophilic areas under H&E stain. Sometimes what happens is that calcium gets deposited around dead cells or necrotic cells in a rounded fashion. And this is what we call Samoma body. So this is a case of pathological calcification of artery. In pulmonary hemorrhage, during chronic venous congestion of lungs, heart failure cells contain which pigment? Okay, so during pulmonary hemorrhage by chronic venous congestion of lungs, the RBCs, they come out of ruptured pulmonary capillaries. When RBCs come out, along with it, ruptured RBCs and its hemoglobin comes out as well. The hemoglobin, it gets oxidized or converted to a pigment called hemosiderin. This hemosiderin is then engulfed by the pulmonary or alveolar macrophages, resulting in the formation of hemosiderin laden macrophage. Basically a macrophage, pulmonary macrophage containing hemosiderin pigment inside of it, and this is what we call heart failure cell. So the heart failure cell contains hemosiderin pigment inside of it. Why heart failure cell? The reason for that I will be telling under the topic of congestion. So for now, you have this pulmonary macrophage which contains hemosiderin engulfed inside of it, called heart failure cell. So the pigment is hemosiderin. And when you look at a microscopy of chronic venous congestion of lung, you can see lots of such cells, So there will be macrophages, and these macrophages will have engulfed hemosiderin inside of it. A 75 years old male, notice the age by the way, 75 years, presented with difficulty in urination, dribbling, increased frequency and nocturia. See, around urethra is present the prostate gland. As you age or at an older age, there is high levels of dihydroxytestosterone present in the body. Dihydroxytestosterone is responsible for the development of prostate gland. Since at an old age, dihydroxytestosterone is present in excess, there is excess development of prostate gland. There is abnormal or a much excess growth of prostate gland. As a result, the urethra, it gets compressed and there is difficulty in urination. In this case, there's an excess growth of prostate gland in the form of hyperplasia. That is, the growth of the prostate gland takes place due to increase in number of cells in the prostate gland. So this is a case of benign prostatic hyperplasia. Let's look at the microscopy. Here's some microscopy. Here's some microscopy. So I said that in benign prostatic hyperplasia, there is abnormal growth of prostate gland. This occurs due to increased dihydroxytestosterone, and there is increased number of cells in the prostate gland. As a result, you will find lots of glands that are proliferating, formation of new glands. There are three major microscopic features of benign prostatic hyperplasia. First, there's formation of lots and lots of new glands or proliferating glands. It's not just glands that are proliferating. The stroma contains fibers, and these fibers also, they proliferate, or there is formation of new fibers. So you have proliferating fibers, and there is also formation of corpora amylaceae, which is present in the gland. Here we have hyperplasia of the endometrial lining of the uterus. So the endometrium of the uterus contains glands, and during endometrial hyperplasia, there are lots and lots of glands. Glands are present more than the stroma itself. So glands greater than stroma in the ratio 3:1. A 50 years old female presented with severe pain in the lower calf muscle with absent pulses in the dorsalis pedis artery. Biopsy of blood vessel is given. So what we have here is a biopsy of an artery. This is the artery, and inside the artery you can see something. This something present inside the artery is a clot. Now the thing is, this clot is formed without the rupture of the artery, or there is no bleeding taking place, yet there is a formation of clot. So we call this a thrombus. So what is a thrombus? Thrombus is a clot that is formed in a blood vessel without the rupture of the blood vessel. So it is a pathological condition. Since it is formed in the artery, it's an arterial clot, and these, or arterial thrombus. And thrombus is usually formed at leg region or around the leg region. Interesting fact about arterial thrombus is that microscopically alternate dark and light bands are present, where the dark band is composed of red blood cells and the light band is composed of platelets and fibrin. These alternating dark and light bands, they are called lines of Jahan, and lines of Jahan are only present in arterial thrombus, not in venous thrombus. The lungs of a left heart failure patient was seen indurated brown on autopsy. The lung was biopsied. See, we have an organ right here. The deoxygenated blood from the organ gets drained through the vein. Let's say this venous drainage gets impaired. As a result, the deoxygenated blood gets accumulated in the organ, and this shows various complications. Let's say the impairment, it worsened over time. So the accumulation of the blood increased over time as well. This is what we call chronic venous congestion. Chronic because the condition worsens over time. Venous because it's the vein that is responsible or vein that is affected. The venous drainage is getting impaired. And congestion because there is accumulation of fluid in the organ. The example that we are given here in this question is of that of a patient with left heart failure. What happens when the left heart of the patient fails? The left ventricle stops working, so the blood cannot be pumped into the aorta and to the rest of the body. As a result, the blood gets accumulated, and this accumulated blood, it has to go somewhere, right? It goes back through the pulmonary vein into the pulmonary capillaries. So there is accumulation of blood in the pulmonary capillaries. As a result, chronic venous congestion of lung takes place. Due to a problem in heart, a problem in lung takes place. Due to heart failure on the left side, chronic venous congestion of lung takes place. During chronic venous congestion of lung, the lung becomes heavy and firm due to accumulation of blood, obviously, and it is brown indurated. The reason I'll explain under the microscopy. So let's look at the microscopy. So we have a microscopy right here. In order to understand these various features, first you need to understand this story right here. So there was a left heart failure. As a result, the heart was unable to pump the blood into the aorta and then to the rest of the body. As a result, the accumulated blood, it flows back into the pulmonary capillaries. Then what happens? There is accumulation of blood into the capillary. So there is increased hydrostatic pressure. Due to increased hydrostatic pressure, there is vasodilation of the capillary. And when there is vasodilation, the exudate through the capillaries, they come out. This exudate, where do they go? They go in the interstitium. As a result, you get interstitial exudate. Interstitium is the space in between the capillaries and these alveoli that you see right here. Obviously, when you take a microscopy of the lung, you are going to find alveoli and the space in between the alveoli where the capillaries are found. That space gets filled with exudate. When exudate increases, this enters the alveoli and you even get alveolar exudate. Okay. Now what? Now the capillaries, it gets swollen so much that the capillary, it ruptures. When capillary ruptures, blood cells, they come out, RBCs come out, red blood cells come out, hemoglobin comes out, and this gets accumulated in the interstitium. Also, since there is vasodilation, I repeat, since there is vasodilation, right? The septum, there's one alveoli, there's another alveolus, in between there's your alveolar septum. This alveolar septum, it expands due to the dilation of the capillary, due to the dilation of the pulmonary capillary. There's one alveolus, there's another alveolus, there's pulmonary capillary, there's pulmonary capillary. The pulmonary capillary expands and the septum expands as well. So you will be able to see that as well. Then obviously alveolar exudate and blood in alveolar space due to the bursting of the capillaries. See, there's one very important term, heart failure cells. Let me explain that. But before, let's revise the whole thing. Hydrostatic pressure increases, vasodilation takes place, exudate comes out, the exudate fills the interstitium, then the exudate enters the alveoli, then it fills the alveolar space. Okay. Hydrostatic pressure increases so much that capillary ruptures, hemorrhage occurs, blood and hemoglobin comes out. This hemoglobin gets oxidized to hemosiderin. This hemosiderin gets engulfed by macrophage found within the alveoli called pulmonary macrophage. So the pulmonary macrophage engulfs hemosiderin, and this thing right here, that is pulmonary macrophage along with hemosiderin, is what we call heart failure cells. So heart failure cells are seen in lungs due to failure of left side of the heart. So you can find a lot of these heart failure cells in chronic venous congestion of lungs. So they are present within alveoli. You can see lots of hemosiderin laden macrophages or heart failure cells in this microscopy as well. So all these macrophages, they have engulfed hemosiderin, so called heart failure cells. A leiomyoma was biopsied and a glassy appearance was seen under microscope. So this right here is a uterus, and these are nodules on uterus, which are leiomyoma nodule. Leiomyoma is a smooth muscle tumor which is benign, and that of myometrium, or the smooth muscle of the uterus. When you take a section of leiomyoma and look at it under a microscope, it appears homogeneous and glassy due to the deposition of proteinaceous substances. And this proteinaceous substances deposited in leiomyoma, making it look homogeneous and glassy, is your hyaline change, which is associated with reversible cell injury or any kind of cell injury. When there is cell injury, there is deposition of proteinaceous substances, and hyaline change is one of them. Here, the hyaline change deposition takes place in between two cells. So it is extracellular hyaline change. Localized pus is called an abscess. And as you know, pus is a battleground where you can find parenchymatous cells, neutrophils, and macrophages all together floating on an exudate where cells might be dead, or it might be dying, or it might still be alive. So if you look at a microscopy of abscess, you are going to find lots of blue dots, and these blue dots are nothing but the nucleus of neutrophils. So you are going to find lots and lots of neutrophils. A patient presented with a patch in the arm which has hypoesthesia and an enlarged ulnar nerve of the same side. During leprosy, leprosy is caused by acid-fast bacilli, Mycobacterium leprae or Mycobacterium lepromatus. During leprosy, two parts mostly get affected: your skin and peripheral nerve. In skin, lesions of various types are seen, that is, patches are seen. These patches are usually well demarcated, that is, they have a proper boundary, central hypopigmentation, and erythematous or slightly red due to vasodilation. Okay, in peripheral nerve, damage occurs which leads to hypoesthesia or paralysis of limbs or eyelid. Perineural inflammation occurs and the nerve might damage completely. Under microscopy of the patch or the lesion, this is what we can see. So there are granuloma formation, and some of these granuloma, they move in a snake-like pattern following or encircling or surrounding a neuron along with it. So there is a neuron here, and the granuloma, it surrounds the neuron and passes or flows along with the neuron. A vasculitis is biopsied and fibrin-like deposition is observed under a microscope. So this is probably a case of fibrinoid necrosis. It's a case of fibrinoid necrosis. In fibrinoid necrosis, which is usually seen in case of vasculitis or inflammation of blood vessel, the middle layer or tunica media, the muscular layer, goes through necrosis and shows under a stain under a microscope a circumferential or a circular bright pink area. So you can see this circumferential bright pink area of necrosis in tunica media of the blood vessel, and this circular bright pink area contains deposition of fibrin like substance and dark nucleus of neutrophils, and inside the blood vessel is obviously the blood. A 50 years old male presented with bleeding per rectum. Pretty vague history. It could be anything, it could be piles, but then a microscopy is given with it. Before looking at the microscopy, a little concept. Adenoma. Adin refers to gland and oma refers to benign tumor. So adenoma is a benign tumor that is either glandular in origin or glandular in pattern. It doesn't have to be glandular in origin. Even if it looks glandular in pattern, it's adenoma. The malignant form of adenoma is benign. The malignant form is adenocarcinoma. An example of which is gastric cancer. So we have a slide right here of gastric cancer. We have a slide right here of gastric cancer. If you look at the slide closely, you can see that there are your gastric glands. However, these gastric glands are not organized in a systemic pattern. They are randomly scattered and they are highly unorganized. Some are here, some are here, some are there, some are here. So this is most likely adenocarcinoma of stomach. Another feature is you can find these adenocarcinoma highly undifferentiated cells. So these are poorly differentiated adenocarcinoma cells. So this shows that the case is that of stomach cancer. Here are few practice questions for you, and then you also have the microscopy of gastric cancer. A patient presented with liver mass and abdominal pain. USG shows multilobulated cystic structure in liver. So what exactly is this cystic structure found in the liver? So hear me out. We have a dog right here which is infected with Echinococcus granulosus or dog tapeworm. In the feces of this infected dog, we can find eggs of dog tapeworm. Let's say these eggs along with the feces gets carried by a fly to food and water. So along with the feces, the fly carries the eggs as well. So the food and water is not just contaminated with the feces but also with the eggs of dog tapeworm, which came from the dog infected with the dog tapeworm. Now you eat and drink this contaminated food and water. Along with food and water enters the eggs of dog tapeworm into your gut. Inside the gut, the egg hatches and the larva comes out, which is called hexacanth larva. This larva can now enter into blood circulation. It either enters portal circulation or systemic circulation. It mostly enters portal circulation and reaches the liver. If it enters systemic circulation, it reaches to other organs. Inside the liver and inside other organs as well, the larva forms a cyst. This cyst is called hydatid cyst, which leads to hydatid disease. So most often hydatid disease is seen in liver through passing through portal circulation, but then it can also occur in lungs and then brain and then bones and then other organs if it passes through systemic circulation. The hydatid cyst has a structure something like this. There's outermost pericyst, the middle ectocyst, which is laminated, and the innermost endocyst, which is also the germinal layer. To this endocyst are attached brood capsule, and this brood capsule gives rise to daughter cyst. If you look at the microscopy of this hydatid cyst, most of the time you will only be able to look at the ectocyst or the middle layer. So here's your microscopy, and what you are looking at right now is the ectocyst of hydatid capsule. That's why you can look at a structure which is laminated, acellular and eosinophilic. Laminated. So it's ectocyst of hydatid capsule. As for your last question, you have to diagnose me. So this is a picture of me when I was younger, And if you look at my chin, there's a black patch on it. This is what the black patch looks like right now with beard on top of it. So what is this black patch? I have a microscopy of this black patch. Here's the microscopy. Under microscopy, you can see that there are lots of melanocytes in the dermis and even in epidermis. They are arranged in clusters and we call these clusters nests. So there are nests of melanocyte. You can even find melanin, which is the brown colored pigment produced by melanocyte, which gives the patch on my chin its color. Another thing is that over the years, the size of this patch hasn't increased that much. That means it's a benign growth. So what I have here is a benign growth on the skin formed by a cluster of melanocytes. And this is what we call nevus.